All right, thanks, Rashawn. I agree with everything except for the Bill Stevenson, Greg Michelle comment. But listen, thanks for the opportunity about talking about this important arrhythmia. Thanks for the wonderful job you're doing. I mean, I think this what you've done in this, you put this together in this COVID era for fellows teaching is just remarkable. I hope we can keep this going post-COVID era. So anyways, let's get along with it here. So we're going to talk about management of LV Summit VT. And I say VT, I mean PVCs, also non-sustained VT, and of course monomorphic VT. So some of these cases can be pretty downright challenging. My goal here is to kind of discuss a systematic approach to this arrhythmia in the EP lab, and hopefully we can make these cases not so daunting and sometimes even fun. Let's see here. So remember these arrhythmias, we're going to kind of call them as a subset of outflow tract VT and can present as I said, as PVCs, non-sustained VT, monomorphic sustained VT. The mechanism is proposed to be the calcium overload. So we're talking about delayed after depolarization. So we're talking about triggered mechanism here. They can comprise to about 10 to 20% of the outflow tract VT. I feel like I see a lot higher in my practice, at least in Loyola. In terms of, why is it important to go after these? They concerning cause troubling symptoms for the patients, but if you have high enough burden, they've also been implicated in developing PVC-mediated cardiomyopathy. So very important to know how to get rid of these things. Here's the outline of my talk. The first and the most important element, I think, is the anatomy. Once you understand the anatomy of this region, everything else becomes very intuitive. We'll then talk about sort of a systematic approach, which starts with, to these LV Summit VT cases, which starts with ECG localization. Remember that the ECG localization is important because it allows you to sort of set expectations in clinic, allows you to do a better job explaining risks to the patient, but it is also very sensitive to electrode position. We will spend time talking about ICE imaging. Again, a very important feature in these arrhythmias, both in terms of safety and efficacy, allows you to see some very vital structures in this region, allows you to see where your catheter is when you're doing mapping and ablating. Then we're going to talk about a systematic approach to mapping all these structures adjacent to the LV Summit. Sometimes when you are trying to ablate the LV Summit, it's precluded because of either coronary blood flow, or it could be epicardial fat. So what you have to do is you have to basically systematically map all the structures that are adjacent to the LV Summit and figure out where you're going to ablate to get rid of these arrhythmias. So in the next 6 slides, we're going to go over the anatomy of the LV Summit and the surrounding structure. I would say that these are probably the 6 most important slides of my talk, so try to pay special attention here. After that, I can start dozing off if you want. So again, anatomy. This is the key. Once you get a handle of this thing, targeting some of these arrhythmias becomes quite simple. So all right, so what is the LV Summit? So if you look at the McAlpine definition, it is the highest point. If you're looking at the LV from the LPO view, so this white area here is pointing toward the LV Summit. The image on the right here is the left ventricular ostium, so the aortic valve and the mitral valve have been removed. So the bases of the left coronary cusp, the right coronary cusp, and the mitral valve are basically form the LV ostium, and these are the sources of a lot of the ventricular arrhythmias that arise here. So you can see the LV Summit is located as the upper end of the anterior interventricular groove, which is right here, shown by the red dots here, and between the upper end of the AIV, anterior interventricular groove, and the aortic portion of the LV ostium. So that's where your LV Summit is going to be. Let's look at this view here. So this is a sagittal view of the heart. You can see that the aortic root kind of occupies the middle of the heart. And it's surrounded by all the different structures here. So anterior, you have the RVOT, and the pulmonic valve here is designated by this blue ring. So remember the aortic valve and the aortic root and the pulmonic root kind of cross over each other. So that, see, the RVOT is anterior and goes leftward. The LVOT is posterior and goes rightward. This complex orientation creates the complexity in terms of both ECG localization, mapping, and ablation in this region. The LV Summit, which is right here, is close to the anterior part of the RVOT and the left coronary cusp. We're going to see this better in some of the other views, and we'll talk about that in a second. The other thing to kind of pay attention to in the coronal view is that the pulmonic valve is higher than the aortic valve. It can be about 1 or 2 centimeters above the aortic valve here. So what happens is you get this interventricular fold. So we talk about the RVOT septum, it's not really a true septum. You have this invagination and then you have this interventricular fold. So you can ablate in the RVOT septum and actually get a pericardial effusion if you get a perforation here. Remember, a lot of these arrhythmias in the outflow tracts are going to be perivalvular. So the RVOT is going to be near, up and around the pulmonic valve. The LVOT, a lot of these ventricular arrhythmias are going to be around the aortic valve. So they're not going to be, they're not going to be higher up by the left main takeoff, so, to give you an example. So we can exploit this height difference to kind of get a sense of where some of these, where you're gonna find the site of origin. So if you're mapping the RVOT, you find that the activation times are all early, kind of farther down. It's sort of a broad activation pattern. The activation times are not so great. The pace maps are not so great. And you might want to, at that point, consider looking on the left side. So exploit that height difference to kind of make sense. All right, this is a very important slide here. So imagine the right here, again, is the LV ostium with the aortic valve and the mitral valve removed. The LV summit sits here as the epicardial structure. So the ventricular atrial junction here has both a fibrous portion, seen here, and a muscular portion. The muscular portion is much more extensive. It includes the interventricular septum, the right coronary cusp, and the anterior part of the left coronary cusp. The fibrous portion is almost like a curtain, which kind of extends from the anterior leaflet of the mitral valve down to the non-coronary cusp of the aortic valve. This fibrous curtain, if you will, is the aortomitral continuity, the AMC. So there are some people out there, if you say, well, the VT is coming from the AMC, they may get upset because, well, there's no muscle there, so how can you have VT coming from that? All right, I mean, I'm not one of those guys, but I'm just letting you know. All right, so the image on the left here, so now we have the aortic valve and the mitral valve put back in view. The AMC is kind of tethered both anteriorly by these fibromuscular extensions, and this is the left fibrous triangle anteriorly, and posteriorly is the right fibrous triangle. By the way, the right fibrous triangle is kind of where the AV node hangs out as well. So if you have a catheter that's, sorry, let me do that. If you have a catheter here that is placed sort of through the aortic valve, if you go in the direction of the mitral valve, you're going to be touching the aortomitral continuity. If you counterclock it, you're going to hit the endocardium, and what you're doing there is you're hitting the left fibrous triangle. So the aortomitral continuity, the AMC haters, I guess, would say that it's not the AMC where the VT is coming from, or the PVC is coming from, it's the left fibrous triangle. It's simply an endocardial extension of the LV summit here. Now, if you were to clog your catheter, you're going to get more subtle. You're going to get to the right fibrous triangle, and sometimes you can actually record left-sided history. So again, I think this is a very important view from a Calpine. It kind of gives you a real understanding of where the LV summit is and some of the adjacent structures here. So now, since we know where the LV summit is, again, it's sort of, here's the anterior interventricular groove, okay? The LV summit is pictured by this sort of like shaded red region in all these, in all these views. So one way you can get to it is by the RVOT, right? So come across the tricuspid valve, go to the anterior septum, high anterior septum, just underneath the pulmonary valve, and that will get you close to the LV summit. It also gets you close to some other structures here. So you can see is you're right there by the LAD, all right? So who says you can't take down the LAD by ablating the RVOT? That's one of the complications you need to worry about. You can also get up and across, up and around the pulmonic valve. That'll get you right up next to the LV summit region as well. You can come transaortic, that'll get you the LV summit. And then also just directly into the left coronary cusp. The base of the left coronary cusp will make you get close to the LV summit. The reason I'm showing you this is because, okay, if you have so remember, see how the LV kind of tapers there? If the ventricular arrhythmia, the site of origin is right at the tip, well, guess what? You can kind of live from all over the place, right? But what if it was down here? What if it was intramural? That's when things can get a little bit challenging. So again, it's a nice view to look at and how you can approach the LV summit in different ways. One other way to get to the LV summit region, which would be the region right here, it's the highest point in the LV, the LPOU, it's just more of an AP view, I'd say. is by using the coronary venous circulation. So here's the coronary sinus, turns into the great cardiac vein, and then kind of just runs down the anterior interventricular groove as the AIV. So if you put a catheter in the coronary sinus, you're going to get right up into the LV summit. In fact, the great cardiac vein bifurcates or bisects this region. There is an extension of the great cardiac vein that actually runs more subtle and goes between the pulmonary artery, pulmonary trunk, and the aortic trunk. Different names have been used to describe it. This is the LV summit vein, is the communicating vein, or the distal branch of the GCV, whatever you want to call it. Sometimes you can exploit that. You can actually put a catheter down that LV summit vein and get recordings directly on top of the LV summit. So that can be helpful too. This is just me just drawing you kind of catheter, kind of showing, coming up the GCV right up to this red shaded region of the LV summit. All right, so as I said earlier, the GCV kind of bisects the LV summit. So this is the highest portion of the LV summit, which is, like I said, kind of where the LV tapers. So how far does it go? Well, it depends on which definition you look at. So one of the things that says is the base of it is from the first supple perforator through the left circ. So the GCV essentially bisects the LV summit region into two regions. So there's one that's more basal and subtle, and there's another region that is more apical and lateral. The basal and subtle region has been called the inaccessible region. You can see why. You're going to be right up next to some of the coronary circulation. You're going to be right up next to some of the epicardial fat here. In fact, this region, the subaortic region, is where you can see some of the highest content of epicardial fat. Interesting to point out here, look at the coronaries, they kind of run in the epicardial fat. So if you're in the GCV, which runs closer to the epicardial surface here, you can probably safely ablate here because the fat can insulate the coronary blood flow and get rid of these LV summit arrhythmias using the GCV here. I'm not saying that you should rely on the epicardial fat. I mean, I think if you're in the GCV, you always have to do a coronary angiogram to make sure that you're at least about a ½ centimeter away from any great epicardial vessels before you apply RF. All right, so I think that's sort of like a summary of the anatomy of this region. I think it's very important to understand that. I think it helps you kind of get a better sense of sort of the ECG features of this region, which we're going to talk about next. And my goal here is to kind of go through this systematically. We talked about the anatomy. We're going to talk about the ECG features, and we'll look at some of the fluoroscopic imaging. We'll look at the ICE imaging, and lastly, we'll look at electroanatomical mapping of this region. I feel like this is more of an anatomy talk than anything else. Because at the end of the day, what you're going to do is you're just going to map all these regions near the LV summit and the LV summit itself sometimes by using the GCV and figure out where your best activation times are, best pace maps are, etc. before you apply RF. All right, why don't we take this question? So this question number one, what is the most likely site of origin of this PVC? So the choices are posteroseptal RVOT, the left coronary cusp, the right coronary cusp, and the LV summit. So why don't you guys go ahead and answer that?
I'll give him
I feel like you guys are putting a lot of thought into this. This one is meant to be not tricky. That might give you a little bit of a hint there. All right. Are we sharing the results here? Okay, well, majority of you got it right. So this is in fact the posteroseptal RVOT. So remember, lead V1 is directly behind the right side of the sternum. RVOT is directly behind that. So most of the vector in this region is going to be going away from a V1. So what you're going to do is you're going to inscribe a small R big S or a QS in V1. The posterior RVOT, do I have to share results here? All right, here we go. We got 42% got the RVOT, correct. All right, let's get rid of that. Okay. Some of the posterior RVOT is more subtle, so you're going to inscribe a narrower QRS. It's going to be less than 140 milliseconds. Since it is more posterior, there's some of the vector forces going in the direction of the anterior precordial lead. This results in an earlier transition. Since it's also posterior, you engage the conduction tissue faster. You can activate the right and left ventricle together simultaneously, as compared to the anterior free wall RVOT, where you get like a sequential activation of the right and left ventricle, which then results in sort of a notching, characteristic notching in the inferior leads. The PA is a little bit tricky. There's no really good ECG features, but what's interesting is that there's these muscular extensions that go above the pulmonic valve, and the majority of the time, some reports greater than 90% of the time. What's interesting is that the height of the pulmonary valve is often overestimated on fluoroscopic imaging. So the actual ventricular arrhythmias that are targeted in the RVOT, maybe the pulmonary artery ventricular arrhythmias more than half the time. Like I said, there's no real specific ECG features, but remember the pulmonary artery goes leftward compared to the LVOT. So, and kind of as it wraps around the LVOT. So you have a vector going away from lead one, you have a vector going away from AVL, and going more towards lead three rather than two. And since it is very high in the outflow tract, you're going to have more prominent R waves in your inferior leads. All right, let's take question number 2. Same question. What is the most likely site of origin for this PVC? So posterior septal RVOT, left coronary cusp, right coronary cusp, LV summit. All right, why don't you guys go ahead and answer that? So we have about, there you go, okay. So, all right, so we got about half of you voting for left coronary cusp and about nearly other half voting for the left ventricular summit. So it's tricky here. I mean, so the answer is left coronary cusp, and I'll show you some of the ECG features that we'll discuss here in a second. The reason why I also know this is because that's where we mapped it. This was one of my cases. That's where we mapped it. That's where we ablated. That's where we had the best sort of activation times. So that's why I think that's the answer here. Okay, so one of the things, you know, when you start looking at these outflow tract areas, the LV summit and the RVOT, LVOT, is when you're looking at the ECG, you want to try to start predicting the site of origin first. And the first thing you want to look at is your anterior precordial lead. Now, there's a lot of indices out there that I've laid out for you on the slide. I'm not going to go over all of them, but unfortunately, one thing I will say though is that the more complex these algorithms get, the more accurate they also get as well. But the general idea here is that the LVOT is a posterior structure. So you're going to inscribe more of a prominent R wave in the anterior precordial leads. So all these algorithms are basically doing that. So here you're looking at the R wave duration index. You know, your LVOT is going to have a bigger R wave duration compared to the RVOT sites. You can have a bigger sort of amplitude. You can look at transitions and earlier transitions with LVOT sites. You can even look at transition zone indexes where you're comparing the transition zone of the PVCs compared to sinus rhythm. I'm not going to go through the specifics of all this, but it's all there for you to review. One of the other things you can look at is the earliest onset of the QRS. If the earliest onset of the QRS or the earliest peak or nadir of the QRS is in V2, that is suggestive of an RVOT site compared to the LVOT site. For an LVOT site, again, the earliest onset may be earlier, maybe I can be V1 or something like that, okay? So it would be an earlier transition. So sort of recurring themes. So here's the sort of gradient of flow sort of the ECGs as you go from the most anterior structure which is the free wall of the RVOT, the most posterior structure is the mitral annulus. What happens is you get more and more posterior, and the overall ECG vector forces start going in the direction of V1, V2. You start inscribing it more and more of an R wave in V1. So you have almost no R wave in lead V1, then you have a big R wave in lead V2. All right. The free wall will also give you this characteristic notching that we talked about. You know, I don't want to go through all this stuff again. We kind of looked at this. The one thing I will mention is this PBCs. You're going to have a very narrow QRS. You're getting the conduction tissue faster. Characteristically, you have a sort of an isoelectric, sometimes even a negative AVL, something to look on for. We'll talk about the LVOT sort of ECG features in this next slide here. Generally, what you're gonna see is you know, broader R waves, taller R waves in your anterior precordial leads because the LVOT is a posterior structure. This example that I showed you, this characteristic W or M morphology in V1, which is very typical for left coronary cusp. The other thing that's consistent with left coronary cusp is the small R big S or QS in lead 1. This notch in the downward deflection of V1, I'll show you an example of that down the line, is characteristic of the left coronary cusp, right coronary cusp junction. Since the right coronary cusp is more rightward, you're going to see more of a positivity in lead 1 compared to the left coronary cusp, something to keep in mind. At the end of the day, we can talk about these ECG features all we want. You got to just go out there and map it. This is a nice algorithm. I use this once in a while just to, you know, kind of, it's fun. We look at this when we're doing a PVC, we have a PVC patient on the table, and we're trying to make a guess. This works quite well, actually. In fact, there was a case yesterday, and we were able to predict, you know, where the PVC is coming from pretty accurately using this algorithm. Obviously, not going to go over all these things, but again, it's there for you guys to review, you know, offline. But let's talk about the ECG's characteristic of the LV Summit. And that's what we're here to discuss. So remember, it's an epicardial structure, and the epicardial origin is going to be suggested by the slurring of the initial portion of the QRS. And that can be with describing what's called a pseudo delta wave here, which is greater than 34 milliseconds. You can see this intrinsic core deflection time greater than 55 milliseconds. The myocardial deflection index is more than half, more than 55% of the QRS, entire QRS duration. And then also some of the shortest RS count, but it's broad. So again, all these things are suggesting there's slurring of the QRS, which is suggestive of an epicardial site of origin or epicardial exit. The other thing that is also suggestive of that is this pattern break. So positive, negative, so positive in V1, negative in V2, positive again in V3 is consistent with an epicardial origin as well. Typically, with your LV Summit VT, you're going to have an atypical bundle branch morphology. You have a Q in lead 1. You have a lot of times you have a monophasic R wave in V1, and characteristically the S waves are absent in V5 and V6. All right. So we talked about this inaccessible and accessible regions of the LV Summit. Remember, the inaccessible region, which is this region number 1, is more septal. So typically you're going to get a characteristic of left bundle branch morphology since it's more septal. And since it is more septal, you kind of have like a sort of like a Perry-His look where the AVL is smaller compared to the AVR. The accessible region is more rightward or more lateral. So you're going to inscribe a right bundle branch morphology with this. I don't ever do percutaneous, you know, mapping, epicardial mapping for these. One of the reasons is, again, you know, the coronary arteries are right there. You're really severely limited by that. Your epicardial fat is right there. You're going to be limited with ablation with percutaneous mapping. This is not just an opinion. This has been systematically looked at. The success rate is low with percutaneous epicardial mapping in the range of about 20%. But these are some of the EKG features that you can look at that may potentially predict a successful percutaneous epicardial approach. I generally would advise against it. I think it's probably not worth the risk of doing that. You're going to run into just a lot of roadblocks with that approach. So let's take question number 3 again, just going along the same thing. What is the most likely site of origin for this PVC? The choices are A, postroceptal RVOT, B, left coronary cusp, C, right coronary cusp,